Pneumonia. Pneumonia is infection of the lung. There are various causes. It could be typical or atypical pneumonia. It could be aspiration pneumonia, in which the causative organisms are anaerobes. It could be atypical pneumonia, which can be with infection of Mycoplasma, Legionella, and Chlamydia. Nosocomial pneumonia is a hospital-acquired pneumonia. Gram-negatives, Staphylococcus, and anaerobes are common organisms. In some patients who are immunocompromised, suffering with HIV, tuberculosis, they can have Staphylococcus, gram-positive rods, fungus, viruses, Pneumocystis jirovecii, especially in HIV, and mycobacteria. Alcoholics and IV drug users have Streptococcus pneumoniae, Klebsiella, and Staphylococcus. In the cases of cystic fibrosis, patients can have Pseudomonas, Burkholderia, Staph aureus, and mycobacteria. Patients with COPD usually have pneumonia with H. influenzae, Moraxella catarrhalis, and Streptococcus pneumoniae. Post-viral pneumonias are Streptococcus pneumoniae, Staphylococcus aureus, and Haemophilus influenzae. Neonates can have group B Streptococcus and E. coli infection. Patients who present with recurrent pneumonias have some sort of obstructive lung disease, bronchogenic carcinoma, lymphomas, vaginous granulomatosis, and vasculitis, HIV, immunodeficiency, can have unusual organisms like Nocardia species, Coxella burnetii, Aspergillus infection, and Pseudomonas. This patient may present classically or atypically. Atypical presentation is a gradual onset of dry cough, headache, myalgia, sore throat, and GI symptoms. And classical presentation, there is a sudden onset of fever, productive cough, prurient or yellowish green sputum, or rusty sputum in case of pneumonia or hemoptysis. Patient can have difficulty in breathing, sweating at nights, and chest pain, which is aggravated by breathing. Examination may show decreased bronchial breath sounds, rales and wheezing, dullness to percussion, egophony, and tactile vocal firmitus. Elderly patients, as well as those with COPD, diabetes, and immune compromise, may have minimal or atypical signs of physical examination. Diagnosis requires 2 or more symptoms of acute respiratory infection plus a new infiltrate of chest X-ray and CT. Workup includes the physical examination, chest X-ray, and CBC, sputum, gram stain and culture, nasopharyngeal aspirate, blood cultures, and arterial blood gases. If we are suspecting Legionella, then Legionella urinary antigen detects the sero group sputum staining with direct fluorescent antibody DFA culture. Chlamydia pneumoniae, serologic testing, culture, and PCR. In case of mycoplasma, usually the clinical serum cold agglutinin with serum mycoplasma antigen may be used. The Streptococcus pneumoniae, the urine pneumococcal antigen culture, and viral nasopharyngeal aspirate rapidly test for pathogens and influenza, RSV, DFA, and viral cultures. Management include one has to consider the common etiology when managing the patient. Children between 6 weeks and 18 years, viruses are common, mycoplasma and Streptococcus pneumoniae. 18 to 40 years, mycoplasma, C. pneumoniae, and Streptococcus pneumoniae. And adults, Streptococcus pneumoniae, Haemophilus influenzae, anaerobes, viruses, and mycoplasma. In elderly, Streptococcus pneumoniae is common along with viruses, anaerobes, Haemophilus influenzae, and gram-negative rods. So the patient has outpatient community-acquired pneumonia, less than 65 years of age, otherwise healthy, no antimicrobials within last 3 months. Then the suspected organism are Streptococcus pneumoniae, Mycoplasma, C. pneumoniae, H. influenzae, and viral infections. One can give macrolide or doxycycline. If the patient is more than 65 years of age, comorbidities, COPD, heart failure, renal failure, diabetes, liver disease, alcohol abuse, antimicrobial use within last 3 months, then Streptococcus pneumoniae, Haemophilus influenzae, anaerobic GNRs, and E. coli, Enterobacter, Klebsiella, Staph aureus, Legionella, and viruses. Empirical coverage with fluoroquinolones and beta-lactam plus macrolide should be given. Community-acquired pneumonia required hospitalization. The common causes are Streptococcus pneumoniae, Haemophilus influenzae, anaerobic GNRs, Legionella, Chlamydia, and the treatment is with fluoroquinolones, anti-pneumococcal, beta-lactam plus macrolide. Community-acquired pneumonia requiring ICU care. Streptococcus pneumoniae is a common organism along with Legionella, Haemophilus influenza, anaerobic GNRs, Mycoplasma, and Pseudomonas. Anti-pneumococcal beta-lactams plus azithromycin and fluoroquinolones should be given. Institution or hospital-acquired pneumonia, hospitalized for 48 hours or in the long-term care to 14 days, ventilator-associated pneumonia. Common organism is GNRs, including Pseudomonas, Acinetobacter, Staph aureus, Legionella, mixed flora. Extended spectrum of cephalosporin should be given with carbapenem and anti-pseudomonal activity. We can add antimicrobials to the fluoroquinolones for coverage of resistant organisms like Pseudomonas until the lab sensitivities identify the best single agent. If the critical care or worsening over 24 to 48 hours, the initial antibiotic therapy, suspect MRSA, add vancomycin or linezolid or broader gram-negative coverage. If the patient is an outpatient, then oral antibiotic is recommended. In hospital treatment with IV antibiotics for patients over 65 years of age and for those with comorbidities, alcoholism, COPD, diabetes, and malnutrition, immunocompression, malignancy, unstable vitals or sign of respiratory failure, altered mental status, or multilobar involvement. For the patient with obstructive disease, CF or bronchiectasis, consider adding pseudomonal, staphylococcal, or anaerobic coverage. Pneumonia can develop complications like pleural effusion, empyema, lung abscess, necrotizing pneumonia, and bacteremia. Thank you.